Hello. This presentation will talk about the quasi-experimental design that I came up with for caregiver delirium education. First, just to give a little bit of the background and kind of what brought me interested into this topic is that, I work in the ICU, and what we're seeing nowadays is that there's this aging population, and baby boomers, as they age, they're needing more medical care. And because of the medical advancements that we have, more people are surviving hospital stays and surviving being in an ICU and having a critical illness. And what we're finding is that ICU survivors experience both short and long-term impairments, and that can include physical, cognitive, and psychological deficits. And all of these things have a negative impact on someone's functional performance and quality of life, both short and long-term. One of the particular conditions that relates to being in an ICU and having an ICU stay, having a critical illness, is delirium. And delirium is defined by DSM-5 classification as a disturbance of consciousness with inattention accompanied by a change in cognition, and it develops in a short period and it fluctuates over time. And as I mentioned previously, this is one of the conditions that can be associated with long-term functional deficits, and it has been linked to people having long-term cognitive impairments up to 5 years post-ICU stay. As I mentioned previously, delirium is widely prevalent in acute care, as well as even a higher incidence in the ICU. Up to 80% of patients on mechanical ventilation in an ICU develop delirium, and there's certain risk factors that put you more predisposed to developing delirium, and that includes an advanced age, so being above 65, having a baseline cognitive impairment or dementia, surgical procedures. So if you come in for an orthopedic surgery or cardiac surgery, there's been research that shows that those procedures can lead to having delirium. Of course, as I mentioned already, critical illness or just the environment of being in an ICU, mechanical ventilation, and also in end of life, palliative care, hospices see delirium, and having an advanced cancer. There still remains to be a lot of unknowns as far as delirium goes, but we do have a good sense of the pathophysiology of delirium and, as I previously mentioned, the risk factors. And we're starting to figure out some of the intervention strategies that can be used to either prevent or reduce the duration of delirium. And there's several strategies that are non-pharmacologic that have been proven to be effective in many different studies, and it's been done by several different disciplines, including nursing, occupational therapists, and they've done some studies by physicians as well. And those interventions include environmental modification, so whether that be rearranging the room so that a person can see daylight, have the window open, be oriented to a clock, reorienting somebody frequently, cognitive stimulation, so giving them crossword puzzles or different word games they can do, mind teasers, that sort of thing. And then regulating their sleep-wake cycle, so trying to limit how frequently they're being woken up at night and trying to do more of the care during the day. And then also participation in early mobility, so physical activity earlier on, including very aggressively while they're in the ICU and on mechanical ventilation. And so that is really why I'm so interested in this, because I think all of these interventions that have been proven to be effective are things that occupational therapists already do, and it's something that they're taught in school, and it's part of their foundational process. And it was exciting for me to kind of hear about these things as being effective, because it is really part of the OT practice framework and completely relates to being able to address cognitive impairments so that someone can have a better functional outcome or better functional performance and quality of life. While there are still many unknowns related to delirium research, One particular area that is certainly a gap in the literature and something that I was immediately interested in is caregiver involvement. And right now, there's very little research looking at caregiver education on delirium, particularly in acute care and in an ICU, and also very little literature on integration of the family caregiver in an adult ICU, and that's more commonly happening in pediatric ICUs, and families are really becoming involved in the entire process. They're going to family rounds, they're being educated, and they're being integrated into the care plan. And there's been a lot of positive outcomes with integrating the family caregiver. It's reduced caregiver stress and anxiety, and it's also helped the patients to recover more quickly and have more positive outcomes. And this is very timely because as I kind of have been starting to do this research, there was recently an article published by the Society of Critical Care Medicine talking about guidelines that should be followed for family-centered care and how there really is this gap in what we should be doing and what we're currently doing, and we're definitely not integrating the caregiver enough. As an occupational therapist, it's so important that we're considering this context and integrating the family caregiver into practice and using them to, as a mode for delivering intervention, and we should be definitely integrating them into care. And that brings me to my research question, which is comparative. Does implementation of an oncology intensive care unit family caregiver educational training video on signs of delirium and non-pharmacologic intervention strategies reduce caregiver anxiety level, increase their knowledge of delirium, and improve satisfaction with the intensive care unit care in caregivers of critically ill oncology patients who are over the age of 65 without baseline cognitive impairments or dementia? And I want to compare this to a matched group of patients who receive routine care with no formal caregiver delirium education. Just to briefly talk about the conceptual and operational definitions, I spoke about 3 things that I'd like to identify and understand. One of them is caregiver knowledge of delirium, which is defined as understanding of the definition, the signs and symptoms, risk factors, and non-pharmacologic intervention strategies that the family caregiver can actually implement. And I intend to use the Family Caregiver Delirium Knowledge Questionnaire to determine that, which I'll speak more about later. Another measure that I want to look at is family caregiver anxiety, and that is defined as family caregiver worry, nervousness, unease, experience as a result of a patient being admitted to the hospital. And I'll be using the Hospital Anxiety and Depression Scale, specifically the anxiety subsection. And lastly, I'll be looking at family caregiver satisfaction with ICU care. And what that's defined as is the approach to healthcare that is respectful and responsive to individuals' needs and values. And I'll be using the family satisfaction in the intensive care unit survey to determine that. Here's just a quick overview of what my study design will be. It will be quasi-experimental, pre-post test control group design, and I'm aiming for 100 participants, which will be ICU caregivers. I'll talk more about the participants on the next slide, and each group will receive the pre-test, the experimental will receive the intervention, and both groups will receive the post-test. The participants in my study will be caregivers of geriatric oncology ICU patients. Specifically, the caregiver criteria, they will have to be at least or above 18 years of age, and they have to be considered a family caregiver, which I didn't include in the presentation, but just to give you background as far as what that means, it would be a parent, a spouse, a child, a close friend, and this can also include a friend if it's deemed the primary caretaker by the patient. The person will need to be able to speak fluent English and be above a 6th grade reading level. As far as the patient criteria, the patient will be 65 or older. They will require an active OT order. So if they don't have an occupational therapy referral, I won't be including them in the study. And that, again, is in part for convenience purposes because it will help me flag the patients in the unit. And then the patients can either be medical or surgical because the ICU that I will be working in is a mixed unit. And the patients can also either be on mechanical ventilation or not because the OTs do work with mechanically vented patients in this ICU. Exclusion criteria will be that the patient has had a prior ICU stay during their current hospital admission, which is very common in an oncology setting. Patients with baseline cognitive impairments or dementia. Someone who has an active DNR order, so they still may have an OT order, but they may have an active DNR order, and someone who's been deemed comfort care only or who's capped their medical care, but they may not be a DNR, but they're not receiving active treatment. Now I'll be speaking about the different instruments that I plan to use and the timeline for when I plan to use them. The Caregiver Knowledge of Delirium Questionnaire and the Hospital Anxiety and Depression Scale, I will be doing pre and post test for. And I'll be giving them to people once I determine that they're going to participate and they meet the criteria and they've signed a waiver of consent. And I will also be giving them the surveys within 72 hours of completing the caregiver education. So even if they didn't receive the caregiver education, I will follow up in 72 hours from when I first gave it to the control group. So the first instrument is the Caregiver Knowledge of Delirium Questionnaire. And this I was really excited to find because, as I mentioned, there's very little literature on family caregiver involvement and education on delirium. And I was concerned because this was done for outpatient or for people prior to coming into the hospital in the community, and I wasn't sure if it would fit. So I actually contacted the author and she sent me this, and I think it will work really well and it will definitely give me the information I'm looking for on caregiver knowledge of delirium. And the Hospital Anxiety and Depression Scale, I'm not going to read through these questions, but you can read them while they're on the screen. I specifically am looking at the anxiety subscale, so this should be a quick response, and the way it's measured is on a Likert scale. Lastly, I'll be using a family satisfaction in ICU scale, and I really want to use this to capture overall satisfaction in the ICU, and I want to know if giving this caregiver education improves general satisfaction with ICU care and feeling of involvement from the family caregiver. This won't be given as a pre-test. This will just be a post-test survey that's given, and I plan on giving it within 48 hours of the patient being discharged from the ICU. I've identified several potential limitations of the study. The first is that I'll be creating this caregiver education video, and I'm planning to have the Patient Education Committee within my institution review it, as well as the Patient and Family Advisory Council, which is a group of people, either they've been patients at the hospital or they've been caregivers of patients within the hospital, and they're used on a consultation basis to give feedback about different programs, just to get a sense of the patient and family perspective. And I also will be sharing it with experts in the field who have delirium knowledge as well as family caregiver training. The one thing I won't be doing is pilot testing this educational material with caregivers who are in this particular ICU before I implement the study. The other barrier or limitation that I foresee is that the study will be a convenience sampling, and it will only represent a small number of caregivers in one specific oncology ICU, which really makes it lack its generalizability. And another reason it will lack generalizability, again, for convenience, I'm only using people who have active occupational therapy orders. So, this could be applicable to all ICU patients, but for the sake of convenience, I'm only targeting people who have OT referrals. And lastly, Two of the tools that I'm using, the HADS-A and the FSICU, are both general non-specific assessments, so they're not exactly targeted towards delirium or targeted towards family caregiver education, but they will let me measure what I want to measure without having to create another tool, and they have good psychometric properties. So to conclude this presentation, I'm hoping that the outcome will be that I'll be able to identify a way to improve satisfaction with caregiver involvement, improve caregiver knowledge of delirium, and ways that they can intervene for family members, and also to help to decrease family caregiver anxiety. And lastly, as sort of a secondary aim, I also really want to look at patient outcomes and does it influence their functional performance or the duration of delirium or development of delirium. And lastly, what their discharge outcomes are. Are they going to subacute rehab? Are they going to home? What type of services are they needing? And I just think it would be interesting to also collect that data, as I mentioned, as a secondary part of the study. Thanks for listening in. Let me know if you have any questions or suggestions for how to improve the study.